Now, when doing the lower extremities, especially in a runoff, we have a particularly large challenge ahead of us. Back in the beginning, when these exams were first in their infancy, we used to have to make do with coils that we owned, try to couple them together, and manually move the table. You can imagine what a frustrating challenge in the workplace this was for technologists. And of course, it took at least two of you to be able to accomplish this exam. With modern day technologies, we actually have two methods that are standard now. One is a moving table or stepping table that's automated. The second one is coil switching technology, where not only the coils reposition, but perhaps the table moves also. I won't say that none of you still are not manually having to move the table, but hopefully in the next years we'll see this evolve into more traditional exam approach like CT, where our table does our work for us instead of manually having to move. If we're using phase array runoff coils, we may also have to use the body coil if we do not have such a thing. Surface coils can be used for your feet or lower legs and knees, and the body coil can be used for the femora and the pelvis areas if needed. Your scans must overlap to ensure adequate coverage. If you miss any anatomy, that could be the area exactly where the patient's pathology is located. So we want to have some system of marking to be able to make sure that we've covered our anatomy completely. It's recommended that you fill an IV line with copper sulfate markers taped to it and put it by the patient's leg, or use oil beads placed along the leg to help localize for overlapping your coil placements. Another important key to this particular exam is, since it does involve a lot of scanning and scan time, is that you have your patient empty their bladder, not only so the contrast doesn't pool in there, but so you're not finding a bright fluid signal in the bladder before you even get started. Not to mention, it makes your patients much more comfortable during the exam. Now, if you have to do an extremity that's an extreme extremity, like a hand or a foot, those can be a particularly problem item. If you're having to image the foot, it is important that you position it correctly. So it is recommended that you actually place the feet flat on the surface coil so that the vessels will be perpendicular to the axial imaging plane. You may need to use sponges underneath the knees and straps to immobilize the patient's foot in this particular position. You see here demonstrated the arterial phase on the left-hand side of your image, and then we have complete venous filling on the right-hand image. With our gadolinium enhanced MRA exams, we're able to do some phenomenal studies to actually demonstrate patients' vascular systems just as well as other imaging modalities without the addition of iodinated contrast or ionizing radiation. Two big ones there for safety aspects. This actually is a first pass gadolinium enhanced MRA of the total body. We'll talk about how this was actually generated in just a few minutes, but I think you can see the beauty of being able to demonstrate something like this as far as screening tools. When we're doing our gadolinium MRAs, we can do a single station imaging, which basically is a typical head to foot or craniocaudal coverage of 35 to 45 millimeters of whatever body part we're trying to image, whatever vessel area, or a multi-station bolus chase, and that's what this particular exam was. It's a single bolus where we've actually followed the contrast dosage through to include the peripheral MRAs. Many systems have integrated multi-channel systems built into their MRI systems, and others have moving and incremental table motions that enable us to be able to do this stepping process, is what we used to refer to it in angiography in the past, and we've kind of adopted that term with our moving table. In multi-station contrast-enhanced MRA, we're going to be doing bolus chasing. Bolus chasing is a lot like tornado chasing, only we're doing it inside the human body instead of out in the great wide open. This is going to demonstrate our first station placement over the renal arteries for a demonstration of those vascular structures. This particular exam is going to be optimized with bolus triggering, which is going to be positioned properly within the aorta to start our real scan process when the contrast has reached the proper placement within the abdominal aorta. Our first station is usually a typical size of 40 centimeters. At the completion of the first station, the table will move or the coils will activate for the second station, or perhaps both, depending upon what coil technology you're using. The second station is imaged immediately after the first station, and it is also going to be approximately 40 centimeters on average, and it will demonstrate the femoral arteries. Finally, we reach the third station, again another 40 centimeter slab that's going to be positioned over the lower leg anatomy, and it will be triggered immediately after the second station. When we put all the images together, we do end up with a complete runoff from the abdominal aorta through the iliacs, through the femorals, down into the lower extremities.